Some of the topics that I would like to cover are looking at through the lens of nutrition, aging, also screening adults, geriatric adults for malnutrition, look at what a dietitian is going to look at in their nutrition assessment of geriatric malnutrition, so anthropometrics, labs, client history, food and nutrition history, and a nutrition-focused physical exam, and share with you some of those components. We'll also look specifically at some dietary recommendations for older adults and discuss some nutrition interventions that again, from the perspective of a dietitian, and I'll try to share some examples as well of patients that I've seen, and I'm sure all of you have your own experiences too. So why does it matter? Definitely, nutrition can make a big difference in mental and physical functioning for the older adult. And with prevention and management of chronic conditions and inflammation, all of these leading to better quality of life, more independence, and better health outcomes for the aging adult. There are some nutrition terms that I would like to start off with to consider when thinking about nutrition in our bodies, and then through that lens of geriatrics. Nutrition status is reflecting the storage that we have of energy, protein, fat, and then our micronutrients like water, vitamins, and minerals. With our nutrition status, we're not just looking at what we're consuming, but if there's been any changes or problems with that, then that would be a nutrition problem. That's what a dietitian is looking for, or a nutrition professional, when they're looking at nutrition status of a person. And then nutrition risk is trying to predict the nutrition problems based on all of the current health status. There are so many internal and external factors that impact nutrition just in the healthy adult. And when adding to it chronic conditions and aging factors, there are a lot of factors that are going to be affecting nutrition status. So I'll be going more into detail and talking about these further in the presentation, so I won't take too much time here except to say there's human biology factors, there's pathophysiology, like with aging, that happen where there is less lean body mass and more fat mass, yet there's still a similar need for our vitamins and minerals. Okay, and lifestyle factors, not just for nutrition, but also for physical activity, since that also impacts our nutrition needs and our appetite. Food and nutrition intake, we're looking at both the quantity and the quality, not just of food, but also activity and how medications can impact that, and then environmental factors. So what are some of those physiological changes that we see as adults age? One of the biggest well-documented shifts is in body composition. As individuals age, we see a decrease in bone mass. There is also a decrease in lean mass, which is going to subsequently have a decrease in strength. This is also increasing the body fat mass percentage. There's also a decrease in fluid in the body. And so this can impact our resting energy expenditure, decreasing the calories that are needed in the older adult. All of the mechanisms that this is happening isn't completely clear, but there is that decreased need. And even with the decreased need, there's still a very normal amount of vitamins and minerals that are needed at less of a calorie level, so it can be tricky. As we age, there are sensory perception changes like dysgeusia or abnormal taste. I can think of some patients where you can give them many packets of pepper and they keep adding and adding because they just can't get the taste of spices and seasonings that they once had. Or family members that talk about how, oh, grandma was the best cook, except now she puts all this extra seasoning in and things don't taste quite right. There's a sensory perception that changes as we age. And then the loss of vision, it can be a significant significant problem with eating. We begin to eat with our eyes. If we're eating with our eyes and we have very poor vision, it can be hard to start that process of digestion and salivation if we can't see our food or even have an appetite. So some things that I've seen with patients where we have our plate and then setting the plate in front of the patient and having the patient learn at where on the plate the food is, actually describing the food to them. Maybe they can get a sense of smell for that, which is also affected by the aging process. Or saying like, if you think of your plate as a clock, at 6 o'clock you have this food item, at 3 o'clock you have this food item, just to give them some of that visual appeal to where their food is on their plate right in front of them. Our GI function as we age can be impacted. Considering the chewing ability and how that has changed. How is dentition? That's the first thing I began to think of, but it doesn't just stop there. It's as far as the swallowing and how is that going? Is a patient having trouble with pocketing of food? Watching how they're swallowing their food. Digestion is also impacted. Remember, there's a decrease in fluid in the body as we age. There's also a decrease in salivary production. Do they report having a dry mouth? A lot of medications can cause dry mouth as well. There's a change in gastric acid production so that there can be trouble absorbing some nutrients like vitamin B12. There's also a change with less diversity in our gut mucosal cells. Although it's very individualized, organ function can be shifted or changed in someone who is aging, and considering how are the kidneys functioning, how about is there a decrease in kidney function in that glomerular filtration rate? How about the liver? How about the pancreas, the bladder, connective tissue, neurons? And all of these areas might impact, like with neurons, I think of impaired memory, reflexes, coordination, and this can impact feeding ability to feed ourselves and even just to remember to eat. If that hunger cue is not quite as strong as it once was, some of the patients might forget to eat or just not take time to eat because they just aren't hungry, aren't feeling up to it. And why does this matter with malnutrition being a large risk for this population? Half of older adults are at risk of becoming or are malnourished, and this can significantly decrease the quality of life. Malnourished adults have 5 times increased mortality. They have increased hospitalizations, and not just hospitalizations, but also once they've been in the hospital and gone home, they have 50% more readmission rates. So we need to find people who are at risk or have malnutrition and help them with this condition. Hospital costs are also greater for those who are malnourished. So malnutrition, from the bigger scope, if we're zooming out, it leads to poorer health outcomes, it leads to frailty, it leads to disability, and is definitely a component to aging. One of the problems with malnutrition is, what is the definition of malnutrition? This is a general definition, and I'll talk a little bit more about one from And and Aspen that you may or may not be familiar with. When looking at this one, it says a state of deficit, excess, or imbalance. For the scope of this talk, we're mostly talking about a state of deficit in protein, energy, or other nutrients, and just all the things that affect this negative nutrient intake for people. Malnutrition is a concern for a variety of reasons. In the hospital setting, it often becomes a concern for reimbursement. Patients who need malnutrition help have an increased cost, but also an increased insurance reimbursement. And so having a standardized way to do this is beneficial, not just for the patient, but for stakeholders like staff at the hospital, but also insurance companies. And that can be a whole conversation in itself. So one of the ways that malnutrition is diagnosed, or is recommended to be diagnosed comes from the Academy of Nutrition and Dietetics and a partnership with ASPEN, which is the American Society for Parenteral and Enteral Nutrition. They have adopted this definition that is for patients based on the etiology, including an acute illness or injury. This is a time-based thing. So if the malnutrition is appearing because of a condition that's happened for less than 3 months, then it might fall into acute illness or injury. This might be something like pneumonia or the stomach flu or surgery, causing an increased need or a decrease in intake for that person. Or malnutrition might come in the etiology of chronic illness. If we think of something like chronic, like cancer or a Crohn's disease or ulcerative colitis, where we have a problem with absorption of nutrients over time, then that may indicate malnutrition as well. Or it may present in a social or an environmental circumstance for someone who might have food insecurity or poverty or decreased access to food for whatever reason that might be. So if we look more specifically at conditions or characteristics of malnutrition, thinking in those 3 context areas of acute, chronic, and social or environmental circumstances, there are 6 characteristics to consider that are like red flags to a malnutrition recommendation. And we can give these, all we need is 2 of these 6. So it doesn't take very many to say, hey, this patient needs some extra attention. They might need some extra help. And maybe it's somebody as an outpatient or as in the public. It doesn't have to be in the clinical setting. That's just typically my lens of where I'm coming from. So insufficient energy intake. And we'll show the exact parameters on the next slide. Unintentional weight loss. So that's a big thing, that there is a significant amount of weight loss, usually between 3 to 10%, depending on if we're talking over a week or 3 months or 6 months. But it does need to be unintentional. If it's an intentional weight loss, that changes things in what it looks like. If there's a loss of muscle mass or a loss of subcutaneous fat. If there is fluid accumulation is one of the characteristics, but it can be impacted by many disease conditions and also can mask problems with weight if there is fluid accumulation. So keeping those things in mind. And then the 6th characteristic is a diminished functional status as measured by hand grip strength using a hand grip dynamometer is the 6th characteristic. This table across the top, you can see the etiologies for malnutrition, where we have those acute illness or injury, chronic illness, and then social or environmental factors. And then on the left side, we have those 6 characteristics. The first 2 are the 2 that really have specific guidelines as to amount. So if energy intake in general is less than 75%, it's red flag. Let's look at what's going on here. What are all those internal and external factors that are contributing to that poor energy intake? Have they had weight loss? Maybe it's a 1 to 2% within 1 week, or a 5% within 1 month, or around 7.5% in 3 months. It gives you an idea of how much weight loss matters. And notice that we're not just looking at pounds here, we're looking at percent, because a 5-pound weight loss in somebody who's 250 pounds might not really be very significant over a short period of time, but in somebody who weighs 95 pounds, a 5-pound weight loss is a significant percentage. We're also looking at that body fat, muscle wasting, fluid, and hand grip strength. And we'll talk about body fat loss and muscle mass wasting in future slides. So what do we do with this? For people who are having, who appear to be like they might need a nutrition assessment or have some further intervention by a nutrition professional, we can screen to identify patients, again, clients or groups. It doesn't have to be patients, to see if they could use some further assistance with this. What does this look like? The nutrition screening process is gathering key information. If we think of that last graph, The two pieces that I typically pull from this for a screening are going to be the food intake and unplanned weight loss. There are many different screenings, and I'll show you a list on the next page, but screenings are a very efficient way to screen patients to see if they need further intervention. It's cost effective. Screenings are typically done by other trained personnel, not necessarily dietitians. Think out in family members could even be heightened alertness to if a family member or friend seems to be at risk for malnutrition. In the hospital that I work at, the nurses do the nutrition screening, and then those who are at risk would benefit from a full assessment that includes that whole nutrition care process. So these are some tools for nutrition screening. This could be, again, a whole talk on itself. It's super exciting to see all the nutrition screening tools that work in different settings. The two that I highlighted in green are the two that stick out to me the most, especially with the geriatric population or those in general living. I love the Determine checklist. It's an acronym that puts risk factors with each of the letters of the word determine, and it's looking at things like, are you eating most of your meals alone? Do you skip meals? Do you run out of food at the end of the month to pay for enough food? Do you have trouble eating a certain food group, or do you have a disease condition that's impacting the food that you intake? Are you having trouble with chewing your food? So the determine checklist I typically will use for somebody who is still living in their home and we're trying to see what areas the patient is at risk for. The malnutrition screening tool is typically more often used in a hospital setting. The reason I like this one, and this is an example of it, is because it's super short and easy to complete to see if there is a risk. It really only has two questions. And the first is, have you recently lost weight without trying? So this is a screening, and it's no or unsure or how much weight has been lost. This, I do notice, is done in pounds, but that means that if there's a weight that is over 14 pounds, or if the person is also eating poorly, it's automatically going to trigger that extra nutrition support for that patient. So that's called the malnutrition screening tool. So what happens if somebody is at risk for malnutrition? Then looking at the patient from that nutrition care process, including these areas of the nutrition assessment. And I did say them previously, and you can see them here, and I'll actually be talking about them each on the next slide. So I will just move forward with that. When I think of anthropometrics, what typically comes to mind is height, weight, maybe waist circumference, BMI. The biggest piece, especially with geriatric nutrition I look at, is what is your usual body weight and what do you weigh now? What type of change in weight loss or trajectory over time do we see? The BMI is also often used. We know now that there's pros and cons to this. It is very practical and simple to use, but it does not reflect the body composition changes, especially that we've already talked about happens in the older population, like less lean body mass and more body fat. There's also something called the obesity paradox with this population. And what that is that there appears to be a protective factor for people who are in an overweight status versus those who are in the lower range of the BMI. So typically, if somebody falls in the range of a BMI of 23 to 30, I think of that as a healthy rate, especially 23 to 27 for older adults versus the usual range, which is 20 to 25, and then 26 to 30 is categorized as overweight. I'm not typically going to recommend any weight loss for an older adult that is above a BMI of 25. They'd have to be on a very specific program and doing a lot of weightlifting to try and preserve lean muscle mass, and that just isn't the type of person that I'm usually seeing either. Why is that? Well, with underweight, the exact mechanisms aren't clear, but with underweight, there's fewer protein reserves. If something does happen and treatments are needed, or there's a chronic condition lasting a period of time, or some other risk factors for appetite, there isn't a lot of reserve for that patient. There's also poorer wound healing, a depressed immune system. There's a couple of terms here: sarcopenia, which is the loss of muscle mass as part of aging. And this is happening as we age. It can be, again, unclear exactly why it's happening, but there is a subsequent decrease in REE, or our calorie needs that our body needs. And there's also a condition called cachexia, which can be a physical wasting due to chronic disease, usually like a heart disease or cancer, where our needs are just so high that the patient cannot eat to keep up with these needs. And part of that assessment of anthropometrics and the needs of our patient. When looking at lab values, historically, we used to use, back when I was in college 20 years ago, we used to use serum protein assays, or albumin, pre-albumin, to determine malnutrition and to determine if we're feeding enough protein. But this is no longer recommended to use just our serum protein measurements, our lab measurements. It's not specific to nutrition to detect malnutrition or changes in malnutrition, so these should not be used. These labs indicate illness that's occurring. They're also sensitive to hydration, inflammation, surgeries, and other diseases that are happening. There is also a change in these labs with age that occurs. So instead of using these lab values, that's why we're looking at things like appetite, weight loss, muscle stores, fat stores, and so forth. And we still can look at lab values for nutrition needs. Some of the common lab values that are ran in geriatric patients are vitamin D. I'd say it's a pretty safe vitamin, hard to overdose on. Everyone who lives in this area, at least in the wintertime, should be taking vitamin D, or almost everyone. I could almost argue that. Vitamin B12 might need to be checked in the geriatric population with that stomach acid decrease. Folic acid, lipids are helpful, glucose panels, hemoglobin A1C, those can all be helpful lab values to tell the bigger picture of the health of our patient. This is the biggest: client history. There's so much information to gather from our client. The client is the expert of themselves, right? So getting from the client or from their chart or family members what medical diagnosis we want to consider are affecting the consumption of food. And as people age, I've got some diagnosis listed here that almost seem to be a normal part of the aging process. Is chronic conditions normal with aging? I don't know, but they tend to happen more frequently as we age. So osteoporosis, impacting our bone health, tends to be diagnosed after menopause as estrogen levels are declining. Arthritis is one of the more prevalent chronic diseases, and it can impact our dexterity and pain levels. Diabetes, Parkinson's disease, and tremors, these can really increase our calorie needs that someone needs, but also dexterity, the ability to actually grasp and hold silverware, pick up the food and bring it to our mouth. Intestinal surgeries, if there's any parts of the intestinal tract that are not working due to some type of disease that the patient has, then there may be more likely to have vitamin and mineral absorption problems if they're missing parts of their bowel. And then metabolic demands just naturally were decreasing with time, but maybe increasing based on the medical conditions that the patient has. And then bowel habits, struggling with constipation, diarrhea, getting enough fiber. And as patients are increasing fiber, talking about hydration, thinking about chronic diseases or disease that might occur along with aging and cognitive status, dementia. And again, remembering to eat, or remembering when someone is hungry, remembering how to cook, having the ability to go and get groceries, to drive a car, depression affecting that. And we'll look at it down lower under social, but isolation, social support, family members, the death of a partner. We think of these as part of geriatrics, but also using that lens of nutrition, these all impact the day-to-day food intake. We need to eat many times a day, and so anything that's happening on a daily basis is often impacting our nutrition intake. General physical ability, there's physical limitations that might be impacted from chronic disease or other things that have happened that make it hard to get food that the patient needs, like transportation, needing to depend on others for shopping. I have a lot of patients that don't want to put anybody out, so they don't want to ask someone for help. So hoping to connect them with programs that are available, and then those functional limitations for feeding. And these can all lead to nutrient deficiencies. Social aspects of the client history, culture, religion, family members again, peers, social support. What support do they have? Do they have family around, friends around to help with groceries and cooking, or even just to eat with? It can be really lonely to eat by yourself often, and the loss of a partner. I just had a patient the other day, this was an outpatient for diabetes, that had lost his partner, and he was telling me about learning to cook. So here he is, this gentleman in his mid to late 70s saying, I've never cooked before. My wife did all of the cooking. And that's very common, especially in this area in the rural farm setting where I'm at. And then looking at the economy, has household finances been a burden for a patient to have access to food? Is there services in the area like food pantries, Meals on Wheels, senior centers where they can get food from? What is the economy of the community? Up here in Langdon, we are so fortunate to have a grocery store, and the access to things like fresh fruits and vegetables, they're there, but it is limited during this little desert of winter in February, in January, before things become a little more seasonal again. Food availability and access, and even cost. Oh, and then food safety and sanitation. I had another story of food safety and sanitation that might shift as dementia occurs, or the patient I'm thinking of did have Alzheimer's, and she grew up in the 30s. So she really wanted to conserve water and would wash all of her dishes in a pail of water, which she wanted to keep using that water. So the water she was actually using to wash the dishes was really quite dirty. And then comes about things like food safety and infection. There's nothing new on this slide compared to the slide I was just on, but I wanted to pull out, hey, all of these things in client history that can impact just food intake and appetite, from our senses to our appetite to our teeth, the ability to feed ourselves, medications, and so forth. There are so many areas in our population that are impacting food intake and appetite, and really including the person I'm talking to find out, what's going on for you. I think hydration needed its own spot. Hydration in the geriatric population can be tricky. Oftentimes people are drinking less than 6 cups daily. You've probably heard it too. What do they say? What does a person say, especially at night? I don't want to drink water because I have to get up too many times during the night to pee. So they're actually limiting their fluid intake. Or maybe it's somebody who needs help drinking. Maybe we're in a nursing home and we actually need physical help, or at home, getting the water and bringing it to the mouth, or there's trouble with swallowing. Or in this population, if there's illness like fever, vomiting, diarrhea, are they remembering that they might need extra hydration? And a lot of the symptoms for this, like dizziness, these things can be symptoms of other conditions that they might be dealing with, so they might not realize it's hydration. Other symptoms that we can look for are dry mouth, cracked lips, sunken eyes, and then a good indicator is dark urine, strong odor, depending on which vitamins a person is taking, and certain foods can also affect urine. But generally, urine can be an indicator of dehydration. The thirst, I almost forgot to say that the thirst mechanism is decreased as we age as well. So remembering to drink in spite of thirst. We put a lot of focus on, let's tune into our needs. When are we hungry? When are we full? But drinking when you're thirsty is too late, especially in somebody who has a thirst mechanism that is suppressed. So we need to also drink with our brain and eat with our brain and say, like, okay, we need to be drinking so much a day, whether you set up a pitcher and try and drink that throughout the day, or you have a certain water bottle you fill so many times a day, or you try to have a glass of water or a drink at the top of every hour or something to try and get that hydration in. Still on client history, I promise there was a lot that goes into client history and what's going on with that, but it's not uncommon to be on 5 or more medications as we age. And consider polypharmacy. I'm not an expert in medications, but there are so many different drugs that cause appetite shifts or shifts in smell, taste, shifts in digestion, absorption of vitamins and minerals. I just put 3 on here that came to my mind: metformin and B12 absorption, methotrexate and folic acid, Coumadin or warfarin, and vitamin K. And then there's a slide here that just has a few more on it, but there are a lot of different drug nutrient interactions that can occur with medications impacting nutrition, and the importance of working closely with pharmacists and encouraging our patients to work with pharmacists closely as well. The next section is focusing in on that patient. What do you usually eat in a day? And I like to ask them to go through their day. What time do they get up? What do they typically have in the morning? When's the first time they eat or drink? What do they usually have around noon, or do they have something around noon? I try not to lead too much, but I can't remember what I even had for breakfast. So to ask somebody what they usually eat can sometimes be challenging to recall. In using these tools or tactics to try and get more information from what that food day looks like. And then also, after going through a usual food intake for the day, looking at all the meals and all the snacks, asking if there's any skipping of meals. Are they eating out at restaurants? Are they eating with other people? What is their beverage intake? Are they drinking any alcohol? Do they have tobacco intake? Any food allergies? To try and paint a picture of what the nutrition for this person looks like. How is their physical activity that's impacting their energy needs? What kind of nutrition knowledge do they have? Have they met with a dietitian before? Do they have an interest in nutrition? Are they constantly researching on their own on the internet about nutrition? I've seen all the ends of the spectrum, from very little to no interest at all to someone who is super intrigued, motivated, and interested. And then what types of food and nutrition related skills are present as far as cooking or chronic disease and nutrition that they have. And then the last area of the assessment is looking at a nutrition-focused physical exam. This is a head-to-toe exam where we're looking for any malnutrition that might be present, such as fat loss or muscle wasting, vitamin mineral deficiency, checking out the general appearance that a patient has. How is their energy? Are they lethargic? Are they sleepy? How are they sleeping? And this is another good place where if I'm interacting with a patient, I can ask them about their appetite, their changes in weight. There's a few notes on the right, but I think I'm going to move into looking at bilateral muscle wasting. I debated, this is just so interesting to me, so I thought you might also find this interesting. But the one thing we can see with malnutrition, even in patients who are overweight and obese, is we can see a muscle wasting. And the areas that are common, or the areas that are recommended to look at, are the temporal area, right under the clavicle, the deltoid area, the thighs, the knee, the calf bulb there, to assess the muscle there. And one thing you can do, like on your own, if you put your fingers right at your temples, we'll try and move a little closer so you can see me, and then open and close your jaw, and then move your hands back as you're doing that, you can feel that temporal muscle. And you should be able to feel that. It shouldn't be sunken in there. And we can see in some of our pictures where we can see some sunken inness. And then the clavicle bone, we're looking like right underneath that clavicle. This is your clavicle bone right here. Mine was broken, so I have a little hump there from a skiing incident. But if you take your maybe 3 fingers or 4 fingers and push there, you should be able to feel a muscle there. And in someone who has some moderate or severe malnutrition, it's going to look almost more like a handle. I heard one example of a patient that said, "Oh, you can grab my clavicle," because it was sticking out so far. And we do need to consider, like, is this normal for the patient, or has there been a change as well? And then there's little tips and tricks for the other areas as well for checking the deltoid muscle. And as you hold from the shoulder, moving the hand down and moving the arm up to engage that deltoid muscle, you can feel that muscle there. And in someone where it's wasting, you might feel that there is less muscle. With muscle, we're looking, it should feel more like a chicken breast. It's like a little springy, a little tougher, versus when we're looking at fat pads, we might feel something that feels a little more like a water balloon. So the areas that we can check for a fat loss include orbital fat pads. This is like under the eyes. There's a little fat pad that looks there. And with malnutrition, there's more of a hollowing of the eye or sunken in eye. The triceps is another area, and the anterior low ribs is another area. So these are things that dietitians are now trained on to assess for fat loss and muscle wasting in areas to look for that. Other signs of nutrient deficiency, looking at the hair. Has there been a lot of hair that is coming out? If we take some hair and go like this, are we losing hair? Or are there little curly hairs on the arms or legs indicating corkscrew hairs? This might be a vitamin C deficiency. Looking at the eyes and the conjunctiva, and we can look at the insides of the eyes to look for possible nutrient deficiencies like B6, B12, iron, anemias, copper deficiency. Iron's another one. If a patient is low in iron, this can cause dizziness, it can cause lethargy, it can cause many things that people might attribute to a chronic condition, and here it could be a micronutrient deficiency. Color of the face, the gums, taking a look in the mouth to see, are the gums swollen? Are they pink? Do they have good oral hygiene? And then looking at the teeth there as well. With the skin, looking for good pigmentation. Mouth, is there a rash in the sides of the mouth? Soreness in the lips, burning in the lips might indicate a riboflavin deficiency. Altered taste might indicate zinc deficiency. And checking out nails for a spoon-shaped or just cracking, different things may indicate micronutrient deficiency. This isn't across the board, as there are chronic conditions, there are medications that can also cause these signs and symptoms, but these are some that are related to micronutrient deficiencies. So after we've looked at all of these things with a patient, what are the main problems that we see? Is it malnutrition? Are there other problems? What are we needing to look at? So we're thinking about somebody who has malnutrition or who isn't getting enough food and protein, enough calories to meet their needs. What then is the goal that we have for them? And then there are five different areas of intervention to look at. I think when I was talking about this, doing this talk with Gunjan, one of the first things we were talking about is, like giving high calorie foods, high protein foods, talking about that. And that is definitely a component, but recognizing that there are so many internal and external factors that contribute to that, that is a huge component. Food intake, I would argue, probably one of the most important components of an intervention, but also considering the big picture and everything that is going on. So we will talk about each of these. When looking at the nutrient needs of the older patient, the exact criteria for calorie needs is a guess, to be honest. And a lot of times if we're not directly measuring it with calorimetry, it's a guess. But the equations that are typically used for energy needs are 25 to 30 kilocalories per kilogram per day. A 5'7" adult that is healthy and fairly active older adult might need somewhere around 2,000 calories. The Harris-Benedict equation, the Mifflin-St. Cyr equation can also be used, just making sure that we add any extra calorie needs for somebody who is ill and active. We'll talk about protein on the next slide because that deserves its own discussion. But the macronutrient distribution, or what's the key amount of fat, carbohydrates, and protein for a patient or for the geriatric population, is not indicated. Instead, there's a range. So roughly a third of the calories from fat, focusing more on those mono and poly unsaturated fatty acids, limiting saturated fat, including omega-3 fatty acids in that. And sometimes with people who are malnourished, who have excessive weight loss, it doesn't matter to me if I'm adding calories from saturated fat or monounsaturated fat. If they need calories, they need calories. It might be from whole milk. It might be from butter. We're just needing to get calories into that person. But this is, again, looking at the overall problems and how we are prioritizing what the biggest problems for this patient is. With carbohydrates, about half of calories in the general population should come from carbohydrates, with an emphasis on whole grains. When we started processing food back in the late 1800s, this removed the germ and the endosperm from our grains, leaving the white processed food and getting rid of a lot of the good nutrition. So the emphasis is to try to incorporate back in whole grains. And this is for somebody without kidney disease. The recommendation for fiber, anywhere from 25 to 40 grams. Again, recognizing that as we add fiber, we also need to add fluid, and we should add fiber slowly to prevent constipation. Fluid needs are generally 2 to 4 liters per day, with reminders. And then vitamin D, often calcium, B vitamins are common. Is a multivitamin needed? There isn't exact clear research on if a multivitamin should be recommended. I typically, in somebody who has healthy kidneys, I typically don't think a multivitamin is going to hurt, but food is recommended as the best first option. Protein intake. Protein intake in general, 0.8 grams per kilogram, meets the needs of most adults. There are about a third of older adults that do struggle even to get that amount. And it has been thought that there is an increased need for people that are older, from 1 to 1.2 grams per kilogram. So I would say that that's a better recommendation, is 1 to 1.2 grams per kilogram per day for an older adult. And then if they have acute or chronic disease or injury, this may increase all the way up to 2 grams per kilogram per day, depending on what their problem is. There's also, for the hospitalized patient and some others actually living, that we should have more protein at each meal, focusing at 25 to 30 grams of protein per meal per day. So that's breakfast, dinner, and supper, about 80 grams of protein per day. Oftentimes this means adding protein at breakfast. A lot of people or patients that I see don't tend to have protein with their breakfast meal. And so adding protein to breakfast is often an intervention that we're working on. So one of the interventions, and again, the one that comes right to mind when we're thinking about geriatric malnutrition, is adding food. How do we add food? First of all, just ensuring that our patient isn't skipping a lot of meals. And if they are, maybe setting them up and encouraging them to eat smaller meals more often, having cues or reminders for that. Maybe it's adding higher calorie, higher protein foods to those meals, or maybe it's just getting regular meals served. Sometimes they'll see somebody come in malnourished and they'll come into the hospital and then they'll have a good appetite and be eating great. It's just getting those regular meals, having the interaction, getting the treatment for whatever they were sick for, that helps them eat regular meals. Or we might need to increase calories during the day by adding high calorie foods, high protein foods, things like, we'll look at that actually in a couple slides, so I won't say that here. Incorporating more calories at their best time of day. Oftentimes we'll see patients eat better at breakfast. So then ensuring that, hey, let's give a full meal here. Let's have you start adding eggs to your breakfast, or let's add milk with your meals. Just by adding 3 cups of milk a day, 1 cup at breakfast, dinner, and supper, we're adding 24 grams of protein and probably over 300 calories per day. If food isn't going to be an option I also wrote having liquids at the end of the meal so a patient doesn't fill up on those, and then avoiding gassy foods so that gas doesn't fill them up either. If that's not adding enough calories, then we can add a nutrition drink or supplement like Carnation Instant Breakfast or Magic Cup or Boost or Ensure. Most of the time for these, it's whatever the patient likes that they can afford that fits into their day is going to be what I help them with. There are some like Scanda shakes that have 800 calories per cup, or there's such a variety, it's hard to even stay on top of all of the nutrition supplements out there. Oftentimes facilities will have one or two that they pick to keep on the shelf, and then finding out from the patient, like, what are their preferences for flavoring? Do they like chocolate, strawberry, vanilla, and bringing it down to the exact goal so that instead of just saying, hey, why don't you eat more, we're actually saying, okay, let's have a cup of milk at breakfast and an Ensure in the afternoon to give them something specific to work for. It's more likely that that is going to be helpful. Common supplements are also listed there. How about feeding assistance? I think it's always so telling to be able to observe somebody feeding themselves. How are they doing with that? Are they struggling? Would they benefit from having family present? Or maybe sometimes that's a hindrance. It can go, usually it's beneficial, but it can go either way. Do they benefit from having a nurse assistant or a feeder position sit in with them if they're in a facility, or like a home care person coming in during meal time? Do they need help with meal setup? Do they need some adaptive equipment to help with their dexterity? What position are they sitting at if they're sitting up, or are they kind of slouched over in their bed, making it really hard to reach the tray? Menu selection. Do they just need help selecting from the menu? Maybe they keep getting the general food meal for the day and there's something they really don't prefer about it, but if they would just make a little shift, then that would be helpful. Or same at home. What does the feeding environment look like? What are the odors, the distractions, the temperatures, the location? Is it pleasant? Do they feel rushed, like, oh, you need to hurry up and get done so that we can move to the next thing? Or are they given adequate time? This is a great place to partner with our OT and SLP friends to help us out as well with the feeding environment. And then also working with the medical provider and the pharmacist. Is there a prescription medication that they can take to help with their appetite if it's poor? Or are there over-the-counter or alternative medications that might help? Or is there shift that needs to happen in something medical to try and help with that appetite, or even when they're taking their medication? And then in some extreme situations, maybe there is a need for enteral or parenteral nutrition beyond the scope of this talk. Okay, so some general eating patterns. I won't go into detail except to say there's no right pattern, but there are some good patterns that are recommended. And to me, these are all very similar. The Old Ways Mediterranean diet pattern over on the left side has cultural diversity on their website, where you can download different cultures of older recommendations for eating patterns. The DASH diet is also very common for blood pressure, heart health, and it has some really good handouts for that. There's a My Plate for older adults from Tufts University. They have some good information. Harvard has good nutrition information. The Mind diet is actually a combination between the Mediterranean and the DASH food plan. All of these are kind of the same generalized, let's eat some whole grains, encourage fruits and vegetables, legumes, nuts, beans. Lean meats are a choice as well in these, and encouraging that fiber intake. So nutrition education is the second component of nutrition intervention. We make these great strategies to increase calories and increase protein, but connect with the patient, connect with the person to see, like, what do you know about increasing calories and protein? Why do you think you need that? How is it connected? Maybe they do know, or maybe they don't know, or maybe they just need the reminder that this is what's going to help my body fight infection. This is going to help me have energy to do my physical therapy so that I can gain better mobility. And with that, talking about a lot of the things that we talked about in food intake, but providing that education on meals and snacks and hydration. Maybe things like carrying snacks with them when they go somewhere, or taking, if they're able to be mobile, taking a walk before they eat with their medical provider's approval. Light or moderate activity can increase appetite. Oh, so important, and I haven't said it, making eating enjoyable. It should be a fun, good experience and not something that's a chore and stressful for our patients, including favorite foods with meals, maybe trying new foods. Um, how to add protein and calories. I mentioned adding milk, or maybe adding smoothies, or cooking with milk instead of water, or adding things like cream or extra calories to hot cereal, to cocoa, to pudding, adding jelly, jams, honeys, butter, margarine to things like breads and crackers to give them some extra calories. And this is for malnutrition. We also have to take into account all of the health aspects, cardiovascular disease, and what the priorities are. Other snacks, I mentioned smoothies, milkshakes, ice cream, custards, puddings, fruit smoothies. There are tons of recipes online. If we looked for, in fact, there's dietitians that specialize in geriatric nutrition recipes for adding calories for malnutrition. Non-fat dry milk can be something that can be added to a milk or a pudding to add extra calories and protein. Hard-boiled eggs, adding cheese, adding beans to things can add protein and calories. Eating cottage cheese, yogurt, especially Greek yogurt, adding nut butters or peanut butters, purchasing ready-made protein shakes. So lots of different ideas. But again, this is actually providing that education to the client and pairing up with them. The next component of our intervention, besides food intake and education, is who else do we need to coordinate care with? Is it home delivered meals, meals on wheels, senior centers, grab and go meals, grocery programs if they have grocery delivery, helping them out with that. Maybe there are some supplemental food assistant program like SNAP, or a local child and adult care food program they can participate in. Now, I'm so fortunate because I'm working in a hospital where I do have access to OT, SLP, PT, social work to help looking into these things. But maybe they also would benefit, depending on where they're at, from a specialized RDN, like one that specializes in diabetes or renal diets. Kidney function is going to present a whole another realm of nutrition modifications. And with these chronic diseases, I didn't mention it earlier, but there's so many different diets, like a cardiovascular diet, we're watching fat, and a carbohydrate diet for diabetes, we're watching carbohydrate. And with the kidneys, they might be watching protein. And the question is like, what do I eat? And so it can be very challenging for a patient to feel like they need to watch all of their food intake. But who can we partner with to help our person? So I came up with a brief example. Patient LN was in the hospital living at home, and they screened for malnutrition. They had significant weight loss. The appetite was fine, but there was muscle and fat loss that was moderate. What we did for this patient was discuss specific food items that the patient liked. Milk with meals was a big one. Not skipping meals, encouraging not skipping meals. Developed a regular day with some food preferences in there. Set up a combination of senior meals and home delivered meals, and also connected with someone from the family to get groceries. This patient was also working with other sources from the facility. So with that, today I talked about how malnutrition and aging are related to each other, how to screen older adults for malnutrition, what a thorough nutrition assessment looks like using that nutrition care process, some dietary recommendations for older adults, and then some nutrition interventions to help with food intake.